next case is of a female patient, 32 years old, post-cholecystectomy, obstructive jaundice complicated by biliary leak. ERCP was done 3 times, the last ERCP in 10/2019, showing dilated interrupted left intrahepatic periradicals dilatation, right intrahepatic periradicals dilatation, and CBD with a stricture at distal part with insertion of plastic stent to the left hepatic duct. MRCP showed dilated CBD, right intrahepatic periradicals dilatation, and interrupted left intrahepatic periradicals dilatation. The patient is for ERCP with insertion of 2 plastic stents.
Yes, hello everybody. Welcome back to room 1. I'm
Good
here
morning.
with Rania and Salma and Thomas behind me, and Dr. Mohammed, who's taking care of the patient, so he knows all the story very well. So this patient had a cholecystectomy. She had a possible leak, but finally it was complicated, but there was no leak when Dr. Mohammed did the procedure. You can maybe explain the case because you already know it very well. I'm just trying to take out the stent here, which has migrated a bit.
Yeah, it's 6 months ago. She had a cholecystectomy and she presented with a leak in MRCP. And when we did a ERCP, there is no any more leakage. And I noticed there is a attenuation of both intrahepatic biliary radical and no definite strictures. We insert a plastic stent in the confluence, but after 3 months she had a cholangitis and the occlusion of this stent, and we replaced another stent, but we also notice there is a still attenuation of the left intrahepatic biliary radical. After that we insert a new stent, which is still present until now. The MRCP also showed this attenuation in the left intrahepatic biliary radical, and now we plan to move this stent and do another cholangiogram to evaluate this attenuation. Is there any strictures or just attenuation, maybe ischemic, traumatic, and we will see what we will do now.
Yeah.
And now, Marianna, I think
I have a little issue here with, because even simple things can become complicated. So when you have a state that has migrated a bit, it's against the duodenal wall, as you see here. We try to take it out with a snare, but we have some difficulty in putting the snare around because it's impacted. So what I'll try to change probably the device and get a ratus forceps, like the one Mark Giovannini used yesterday to extract the stent, which was inside the bile duct. Because here, as you see, if with the snare I can't pass around the stent because it's a little bit impacted in the duodenal wall. Open, yeah. Maybe this will work. So don't know if you found the ratus forceps that you used yesterday.
Marianna, could you grasp the flap and then to make it go inside the colodochus a little bit more, and then try to.
Yeah, we can try that. Maybe just move it a bit more. So maybe we can try to do that. But you can close a bit. No. Close, yeah.
Like this?
Yeah, it won't. Maybe a bit like this to move it inside a bit to make us some place.
Yeah.
Okay, maybe release, and maybe we can try to grasp it from underneath now.
Okay.
What do you have for me? This could be a bit better, yes. Thank you. Close, yeah. Okay, you're open? Yeah, this will be okay. Close. Yeah, you have it? Yeah. So now we have with the Ratus forceps, it worked easier. We take off the brakes, we'll extract the stent, and maybe some fluid just to be sure that I go with it. Yeah, okay. So we were talking about the different, we lost it because we didn't have it grab it long enough, so okay, now it's easier. We're talking about the different possibilities of diagnosis here because Dr. Mohammed described that there was a persistent stricture. Stricture, Dr. Mohammed, you were saying?
It's attenuation. I can't delineate a definite situation. So it's just attenuation of the intrahepatic
On the left,
periodical
right?
mainly to the left.
Yeah. Yeah, you're open. Yeah, you can open. Yeah. So the possible diagnosis we're discussing is maybe ischemic cholangitis from cholecystectomy, and maybe ulcerative colitis, because she had anemia, right? As well.
Yes, she has hemolytic anemia. Yeah,
Close.
and we have a proper diagnosis of spherocytosis.
Ah, you have that, so that's
Yeah,
for
it's-
sure.
yes, yeah, good.
Okay. So we hope it comes with us. Oh, la la. Give me the snare now. This is a good exercise, huh? It has been described after a complicated cholecystectomy. You can have ischemic alterations even in the intrahepatic ducts, but it seemed to be a bit curious that it was on the left side. Yeah.
And you didn't notice any stones on cholangiogram or MRCP?
Okay, you can close. Yep. The third one is the good one, huh? There we go. So what we're planning to do here is we'll inject first to have a cholangiogram to see the anatomy.
Sometimes getting the stent out is more difficult than the ERCP
It
itself.
takes more time than the exam, huh?
It happens to all of us.
Usually we leave it for our fellows, but here it was a good exercise for me. So we can have some fluoro. There's a bit, maybe some stones there as well. So we're going to, we have the balloon as well, extraction balloon. So we're going to, we have taken ERCP catheter. You're ready with the guide wire there. And we might need some injection, we will need some injection afterwards to delineate the anatomy. So when there is a sphincterotomy that has been done, usually you will go to the upper part beneath the fold to find the orifice. And now we can push the guide wire. Yeah, okay, I'm somewhere. So we see the fluoro. We're in the bile duct. So what I'll do now is I'll go a bit further up. And we'll inject, you can remove the guide wire, so we'll inject slowly from here. Because the area of interest is in the hilum. So we will inject from there and then come down. So are we ready with the fluoro? Yeah. Maybe it's better to see the fluoro directly. Okay, you can inject Rania. So now we see the anatomy. I think that's the cystic stump that we see there. Yes, we can inject a bit more. And we probably will need a balloon here to extract and to inject with. So now it's okay. What we'll do, we'll put the guide wire again. We'll take a balloon. And then will help us to see the anatomy also better. So the balloon, huh? First the guide wire, then the balloon, yeah.
So you're going to do some sort of occlusion cholangiography? That's your plan?
So here we'll see if there's still a stricture. We have to define the anatomy better. That's why the cholangiogram balloon will help us, the extraction balloon, to have a good cholangiogram. And then we will see if there's any residual stricture and how it looks. This is might mean it's glooped. You can come back with the guide wire. Come back.
Maybe even in cystic duct.
Yeah, I'll come a bit further down. Flora? Yeah, there you are. Okay, you can go up there. So we'll do the exchange. Okay, and then we can take the Fogarty balloon. She must have a bit of stones inside, huh? Because there's stone there. So maybe that's the problem. So you have a 12 millimeter balloon? Yes. Yeah. Okay. Okay. We can take a 12 millimeter balloon. So with the balloon, we'll go further up again, beyond the cystic duct and start injecting there. Because we were at the suspicion of a Hiller stricture, we put the patient with antibiotics, prophylactic antibiotics. I always try to keep myself below the papilla. Maybe we'll just do a balloon swap here already, because I think this balloon is, the stone is further down, so I'll just do a balloon swap now, so you can inflate the balloon, just to clear the distal part. And then we will inject. There's a balloon comes out, so the sphincterotomy is adequate. And you see the maneuver, the balloon extraction maneuver, will show it afterwards. There is a stone that was extracted, or it's like a cast,
Like
a cast of stones. So we'll go further up, comes up some fluoro. And here we will start injecting slowly. Maybe you can show a bit, a little bit go up so we can see, yeah. So, yeah, just to show the intrahepatic ducts, we have the whole picture. So we start injecting, and then you will inflate a bit the balloon, but you can start injecting. Fluoro? Contrast, huh? First you can inject contrast and then the balloon, yeah. Yeah. So this is a double lumen.
Fluoro.
Come a bit down to be near the... So here's the cystic duct, what we think is a cystic duct. You can you can bring back your guide wire and put it in, so it could be in the intrahepatic ducts. Yeah. Yeah, that's... or you may try to go to the right side.
So what kind of wire are you using now?
Excuse me?
The kind of wire
This
that
is
you're
a
using?
35-inch. It's a guide wire with hydrophilic tip. It's a straight tip. It's the Hydra-Jag or the Jag wire, right? That we have
Yeah,
there.
Jag
Yeah,
wire.
Jag. Yeah.
In a structure like this, wouldn't you like to use another
Okay,
more
now you
hydrophilic
can,
guide
just
wire,
eject
like
a
the
bit and then,
acrobat guide
eject-
wire?
Inflate the balloon. Okay, we can inject now. Fluoro. There we see. So that's her confluence there. That's, yeah, that's better. So now I understand what you say, that the intrahepatic seem a bit rarefied, huh? Yes. Okay, I'll go a bit down to see what's going down. So can you follow with the fluoro down towards the... Okay, now I'm
Fluoro
coming down,
down,
fluoro down,
down,
and you can push
down.
the wire to keep in place at the same time. Yeah. So I don't see any residual stones.
But what
And
about
the balloon is
left
out.
side?
And the left side seems a bit irregular. Yeah, here we are out, so you can deflate the balloon. The cystic duct is in the middle. But I don't see any more stricture at the level of the cholecystectomy.
Yeah.
Yeah. And I'll go up last time, so we can go up again on the guide wire, just to see if everything passes nicely. But what I will do in this case here, I would not fluoro again intrahepatic ducts. Yes, the intrahepatic duct, the left side seems a bit like PSC attenuated, like a dead tree. I say the fluoro, yes, but there's no clear stricture, as you say. So I would pass the balloon here one more time to check the if there's no more strictures in the CBD, but I will leave her without any stents at this point. There's no clear stricture, as you say. I would do an MRI without the stents, and maybe do IgG4, exclude PSC with colonoscopy. Yeah, because there's no clear stricture. It seems to be irregular. And okay, now we do a balloon. Yeah. Yeah. Going to inject a little bit more contrast just to have a final view, and then we'll extract the balloon. So it's mostly on the left side that, but there's no stone, huh?
No.
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 Okay, so we will go down. So for the maneuver for the extraction of the balloon, you go underneath your papilla. You bring down the balloon. You ask your nurse to continue pushing the guide wire. You adapt the balloon so you can deflate a little bit here, because her bile duct is a little bit deflate, not too much. You can follow the fluoro towards the end of the CBD. Yeah, your balloon is still inflated. Yeah, you can inflate. You can keep a little bit of inflation in the balloon. And when you bring it down until it's really distal like this, and now it comes out so easily, but what you do, you will put your hand, you will block the balloon with your hand like this, as distally it can go. You will go away from the papilla, you will retract, and then you will push down and clockwise, so that way you extract your balloon in the direction of the bile duct and it's not traumatic. But here I think that we see there's a good emptying as well. So when you can leave it with the guide wire, you can have a fluor, a final fluor. So the emptying is good at the CBD, and you see the duodenum is full, and also the balloon passes very easily. So I wouldn't put any more stents, at least for the problem
there
of
is a hold of
the
contrast
stricture that
in
you had
the-
post-cholecystectomy. And on the intrahepatic, we have to see how she is without anything inside. Okay?
There is contrast hold in
So MRI
the right
didn't
hepatic
notice
duct.
any irregularities with anatomy of the
So we are
intra-
finished here. Yeah.
So you don't think that there is a
No.
stricture at all in this
Okay.
case?
Sorry?
You don't think that there is any stricture, some sort of stricture, especially that the right system did
What
not
did you
drain?
There is
and-
contrast hold in the right system. Can't you see in the cholangiogram?
Please, if you can raise your voice, please.
There is
Can't
contrast
hear you.
hold in the right hepatic duct on the cholangiogram.
But there was no stricture in the intrahepatic
And even
ducts.
the guide wire did not pass through through the common hepatic duct freely.
No, we can't
Cannot
hear
hear you.
Yeah, we cannot hear you.
There is contrast hold in the right hepatic duct, and the guide wire during the procedure didn't pass through the common hepatic duct at all.
No, but we didn't see any stricture when we see the morphology.
There is always kink at during passing the wire through the common hepatic duct.
But she's on the back. They were evacuated at one point, yes. Because when we did the cholangiogram, there was no stricture. So here, when we did the cholangiogram, there was no stricture. She's also on the back, so that's why it's not evacuated immediately. But there's no need to put stents here.
Okay, thank you very much. We will shift to another room now.
Okay, thank you.
Thank you.
I would do an MRI like this and see how she is, and if it could be an ischemic stricture because of cholecystectomy.